αυτό να καλωσορίσουμε τον καθηγητή Βασίλη Χριστόπουλο, απόφοιτο του Πολυτεχνείου Κρήτης, με το δακτορικό από το Πανεπιστήμιο της Μινεσότα και ήταν κάποια χρόνια στο Καλτέκ.
Απόστολε, αν μπορείς να πέσει το μικρόφωνο, αλλιώς δεν θα γραφτεί στην κάμερα.
Ας μην γράφει, του Βασίλη ομιλία είναι να είναι στο μικρόφωνο και μας επισκέπτεται τώρα, είναι στο Riverside και μας επισκέπτεται για να μας δώσει μια ομιλία σε θέματα τα οποία έχουν να κάνουν με νευροφυσιολογία, αλλά και εμπλέκουν πάρα πολύ τεχνολογία και πληροφορική. Ο κ. Χριστόπουλος, λοιπόν.
Λοιπόν, ξεκινάμε κανονικά, έτσι. Ωραία. Λοιπόν, πρώτα απ' όλα να ευχαριστήσω τη Σχολή των Εθνικών Υπολογιστών του ΣΥΜΗ για την πρόσκληση. Προσωπικά τον κύριο Ποστολοδόρα, γιατί ήταν η ιδέα του να βρεθώ στα Χανιά μετά από 20 χρόνια, που έφυγα το 2003 και είναι, θα λέγα, χαρά, συγκίνηση, έτσι, που βρίσκομαι πάλι στους ίδιους χώρους. Αν και αυτός ο χώρος δεν υπήρχε τρεμένο εδώ πέρα. Αλλά περπάτησα πάλι το πρωί στην καφετέρια της σχολής, έτσι, και περπάτησα στις αναμνήσεις του παρελθόντος και θυμάμαι ότι όταν έφυγα είπα δύο πράγματα. Έτσι. Το ένα είναι ότι θα ήθελα κάποια στιγμή να επανέλθω και να δώσω μια ομιλία. Αν όλα πάνε καλά στην Αμερική, ποτέ δεν ξέρεις όταν θα πήγαινε πέρα τι ακριβώς θα γινόταν. Αλλά να επανέλθω και να μιλήσω στους σημερινούς υποψήφιους μηχανικούς του Πολυτεχνείου Κρήτης και οπότε σήμερα εκπληρώνεται ένα μου έργο, ένα μου όνειρο. Το άλλο που είχα πει, αυτό ίσως πάρει κάποιο καιρό ακόμα, είναι ότι όπως είπε και η Βάσο, μου έστειλε ένα μήνυμα και μου είπε ότι θέλω να σε καλωσορίσω στο ακαδημαϊκό σου σπίτι. Αυτό που έχω να πω ότι ξέρεις, ένα από τα όνειρα πάντα έχεις όταν φύγεις από το σπίτι σου είναι κάποια στιγμή να επιστρέψεις πάλι στο σπίτι σου αυτό. Οπότε αυτό είναι ένα όνειρο που κάποια στιγμή θα ήθελα να το εκπληρώσω στο μέλλον. So I'm gonna switch now to English, and I'm gonna do that because what we're gonna see today is something that I have been trained for about like 20 years in the States, working with what we call like the neuroscience, which actually it's a field that you try to understand, to unlock the mysteries of the human brain and beyond. And you're gonna see what's the beyond. So the title of my talk is Functional Ultrasound Imaging, a revolutionary technology to study the nervous system. And I'm going to start by saying that the brain is the most complex structure that we know in the universe. It consists of billions of neurons that are connected to each other with trillions of synapses. And it is responsible for what we see, what we hear, what we feel, what we imagine, what we memorize. It's actually responsible for what we call consciousness. It's responsible for what we are. But unfortunately, these synapses many times, like occasionally actually break down, and this results to what we call neuropsychiatric disease. Very serious disease, such as like the PTSD, migraine, epilepsy, stroke, multiple sclerosis, Parkinson's disease. All of them are generating, they have the source that of something that goes wrong into the nervous system, particularly in the brain. And medicine, all of these years, is trying to modulate the synapses, of the brain to either, I would say, alleviate some of these symptoms, because unfortunately some of them are what we call neurodegenerative, which means that the patient, unfortunately, there's no treatment, will die. Or the most ambitious thing is to stop the progress of a disease and to cure, like a patient. And if I can somehow mention the three different ways that medicine is using for approaching this kind of disease is number one, the neurosurgery. Like very common example is patients that they show drug resistance in epileptic seizures. You have the patient, the neurosurgeons, to go and to scoop out, removes areas of the brain to stop the seizures. We have, of course, the drugs like painkillers, everybody I think have been used in the past, or antidepressants, that you take and you dump serotonin into the connections, the neurons to stop, to cure, depression. And more recently, what we call, clinical neuromodulation, which practically you try to use a drug-free approach by modulating electrically, magnetically parts of the central nervous system or the peripheral nervous system, and you try, to cure the disease. One very common example you might have seen, on YouTube or, in the media is what we call the deep brain stimulation, which actually have patients with Parkinson's disease, in which the neurosurgeon is create a borehole into the scalp and then goes down with a very long electrodes to area like the subthalamic nucleus, areas like that is located deep in your brain, and tries to stimulate to reduce like the tremor that we have seen in the patients with Parkinson's disease. Unfortunately, if we can talk as an engineers, that all of these approaches, most of them, is what we call, and excuse of my control theory background, is what we call an open loop system. So practically we have the physician, like the surgeon, the psychiatrist, the neurologist, to prescribe a course of treatment. They give you some to the patient, and then practically you don't know what you cause to the brain. You have to wait to see the effects of the treatment, and some of them can be actually really it can take actually a long time before you see the effect. I'm not sure if you have an experience, for instance, with depression, but you have seen that patients that they got an antidepressant treatment, they have gone through a lot of trials and error before they found what is the appropriate treatment to alleviate the symptoms of depression. So in my lab, what actually we try to do is we try to close that loop. We're imagining one day that we're going to give them the ability to medicine to be able to immediately detect the effects of a treatment into the brain, and also this is one approach. The other thing is that we want to use the same approach to try to understand the pathophysiology of a specific disease, because in order to restore, in order to actually to cure a disease, you cannot do that if you don't understand the basis, the nature of this disease. So one common way that there's two actually ways that we can image brain activity. One of them is the most well-known electrophysiology. So practically you get electrodes, you go to cells, to the neuronal cells, you dive the electrode there and you just record activity directly from the neural cells. You record what we call the action potential. This is the activity that the neuron generates when it becomes active. We have a very good quality of signal, everybody knows that. The major limitation is that this is invasive, so it requires to open the scalp and go into the brain to record it from the brain, and you can measure only locally the activity of the brain. This is, unfortunately, you cannot hear the sound, it's very interesting, but here is one of our first patient when I was at Caltech with Richard Anderson. So this patient has what we call tetraplegia. Okay, so he has been tetraplegic after an accident on his C3, C4 cervical, part of the spinal cord. Has actually spinal cord injury, and which means that he cannot move any part of his body from the neck and down. So this actually, this patient was implanted with what we call multi-electrode arrays. That's actually electrodes into the brain that directly encodes activity from that brain. What actually you cannot actually hear here, but practically we have an experimenter, one of my colleagues, who actually is asking the patient to turn on and turn off the activity of a single neuron. So what you can see here, this kind of burst that you can see when I'm pointing out, let me see if I can use this kind of thrusters that you can see here, this is actually the activity of that neuron. So when you see activity like that, like an avalanche, a burst of activity, it means that the neuron is active. When you see something like that, more sparse, activity, it means that the neuron is inactive. This is pure, noise. So if you could hear, the experimenter, you would hear that we say to the patient that turn on and turn off the activity of the neuron. So we're going to start, and we're going to give here, it requires you to stop. So you see very low activity, almost no activity. And then when he's going to be asked to turn on the activity of the neuron, you see a very strong, activity. This is when I saw this one for the first time, people think that, how can you control the activity of a single neuron? If I ask you to turn on and turn off your neurons, I think you cannot do it. Like science is magic, but in reality, nothing is magic here. Okay? So that's what we found when we worked with this patient. We found a neuron on his brain that was activated when he was imagining that he's moving his thumb to his nose, his index finger to his nose, and it was turned off when he was imagining that he was moving, his index finger to his thigh. So the command that we give to him that turn on the activity of the neuron, he imagined that he was moving his index finger, to his nose, and when we asked him to turn off the activity of the neuron, he was moving his, he was imagining that he was moving his index finger to his thigh. And this is the basis of what we call brain-machine interface. I hate to say that, but you may have seen Elon Musk and Neuralink that they're developing what they call, which is not real, the first human brain-mass interface. Here, actually, we have shown that we did this one before. The difference that we have with Elon Musk is that we don't have his power to advertise, the work. The university doesn't have the power like Neuralink, and Elon Musk that he owns, Twitter, and he can go and say things which are not, real. But what I show you here is this way. You do this one in animals or in humans. This is how we measure brain activity using electrophysiology. The alternative way is to do what we call hemodynamic signal. So practically here we're measuring metabolic changes in the brain associated with the brain activation. So what we know that when a neuron becomes active, it needs energy to restore the membrane potential, to return back to the equilibrium state. The energy that comes through, the blood, which the blood transfers, the oxygen into the area of interest, and the neurons absorb, the oxygen through, the blood. So this is actually the base of the more well-known, techniques, imaging techniques, like the fMRI that you can see, here. This is an example, of an fMRI that they did in a very small animal. This is in rats, in which they do a very typical experiment that we call the whisker stimulation. They go and they stimulate the whisker, of the animal, and we have what we call the neurovascular coupling. So practically here you can see the neural activity, and you see the change that you can see also of the arteries when you start stimulating, the whisker of the animal. So the idea is that the magnitude and the spatial location of the blood flow changes are directly connected to the change in the neural activity. And this is actually the assumption that we make in functional neuroimaging of the neurovascular coupling. Whenever there is an area is activated, we have an increase of the blood flow changes to that active area. Okay, now we have different techniques. Okay, we have developed over the past year many techniques that people are using, for clinical or preclinical, work to monitoring, brain activity. We have techniques now that they use electrophysiology, like the multilateral arrays, the one that I showed you that they use, for this, patient. The electrocorticography, ECOGs, that they place them inside, the scalp of the patient. We have EEG, similar to the ECOGs, but now non-invasive, that goes outside of your brain, fMRI, fNIRS, and so on. And as you can see here, the different, each of them has different, characteristics, different specifications. Some of the techniques are better than others to some of these, features, but none of them, outperform to all of these, techniques. Like for instance, the multilateral arrays have excellent spatiotemporal resolution, but you cannot apply to a control, to a neurotypical, to a healthy individual, because it requires to open the scalp and put them into the brain. They're super expensive, and they have a very limited spatial coverage. You can image only the activity of your fingernail. This is actually the size of a MIA, of a multilateral arrays. On the other hand, the fMRI is great in terms of the spatial coverage, but it's extremely slow. And again, super expensive. So for years, people will try to come up with a technique that somehow, fulfill all of these criteria, and can be also used for clinical, purpose. And we have, a breakthrough in 2011 with one of my colleagues now, Michael Tandri, from INSERM Institute in France, who found and published in Nature the very first functional ultrasound imaging, technology that you can use ultrasound signal to monitor really fast hemodynamic changes, in the brain. What is now the functional ultrasound? So functional ultrasound is very similar, to the clinical ultrasound, and I bet that most of us, we have, or we may have, in the future. In the way that it works, we have, the probe that has different, elements, here, and this is the area that you want to image, okay? So the way that it works, the clinical ultrasound generates this focus beam sound waves that goes down into the media, and then insonifies the media, and detects the backscatter echo from the red blood cells. The problem with the clinical ultrasound is that it has to do this one sequentially, to turn on each subset of elements sequentially before generate a single image. So this is a very slow technique. Okay, your brain is really fast. In order to be able to use one for functional imaging, to be able to detect functions of your brain, we need to have a technology that is very fast. Okay, so the focus ultrasound actually was a very good technique for imaging the vasculature of the different areas, of the body or the brain, but not for functional imaging. So what the French group did, they generated what they call the ultra-fast ultrasound imaging. So they found a way to generate a plane wave that goes into the brain and detect the backscatter echo of the red process with just one shot. And this is considered one of the biggest breakthroughs ever in the history on functional neuroimaging. So what happened now, we went from 256 transmission for a full image to 1 transmission for a full image. The temporal resolution was improved from 50 frames per second to 10,000 frames per second. Here is a mistake, it's not 1,000, 10,000 frames per second. Spatial resolution from 0.5 millimeters to 5 microns, and the sensitivity to blood was from 2 centimeters per second to 1 millimeter per second. This is very important because the most important areas that we want to image in terms of the vascular system is what we call the capillaries. This is the end, the very tiny vessels that enters into the cortex, into the brain. And this is actually where we have the exchange of the oxygen to the neuron. So we want to be able to image and to improve the spatial resolution, the capillaries of the brain. On the left side here, this is actually one of the animals. They use technology. They put, the ultrasound, probe here. This actually they use the typical clinical ultrasound, and this is the ultra-fast ultrasound. I mean, you don't need to be in the field to understand that this one here has a better contrast to noise ratio. You can see very nice, structure of the vasculature of the rat, brain. One of the limitations I have here is that this technique is still what we call minimally invasive. Minimally invasive, it means that we have to remove the bone, but we don't have to remove the dura. The dura is the area that protects your brain from outside, the skull, okay? So, as soon as you open the dura, we have a completely different story there, okay? It's a more difficult, surgery, and requires to have a neurosurgeon to do these surgeries as soon as you open the dura. As long as you stay outside of the dura to remove the bone, this is more, straightforward surgical, procedure. So here you can see that the ultrasound, the functional ultrasound, the main problem is that if there is a bone, it cannot detect. The signal is attenuated. You cannot detect it, the backscatter echo of the red blood cells. So the very first proof of concept came from the same, lab in 2011. They use the same kind of whisker, stimulation. They stimulate, the whisker of the animal, and they image the brain around an area of the rat brain which is responsive for processing sensory information. And what you can see, here, you can see a movie in which you're going to show the activity of the somatosensory area, of the animal when they turn on the stimulation, when you start stimulating, the whisker. Here is off, it means that they don't stimulate the whisker, and on, it means that they stimulate the whisker. So as we go now, you can see that when they start, stimulate the whisker, you can see that we have a very strong activity. I can see yes. A very strong activity of the somatosensory area. That was actually the very first proof of concept that this technology can be used for the first time to image the functional activity of the brain. Okay, now, I saw this talk when I was at Caltech in 2015, and I was super excited because I found that this was an opportunity to bring this technique to the States and to apply, to bigger animals. My dream is to take this technique to apply to humans, okay? But in this field, you cannot actually bypass, the big animals before you take it to go from rats to all the way to humans. You're not going to get FDA approval to do that. So at this point, I was working with monkeys, and I talked, with people, with my colleagues, and we wrote what actually we call, it's called Brain Initiative. This is actually NIH, the National Institute of Health, funding source. Is one of the most rich funding source. We call it the Obama money, because it was found when Obama was president, and his dream is to unlock the human brain. So we got this grant, and we started collaborating with the Insem Institute in France. We designed and we built the very first functional ultrasound system at Caltech. We used a high-frequency probe of 15 megahertz with 128 elements, 100 microspeeds, which generates an image with a temporal resolution of 100 microns, and this gives us also a temporal resolution of 100 milliseconds. And this actually is a very fast vascular map of the monkey's brain. Interesting, but of an area of the brain which is called posterior parietal cortex. So if you see your brain like this, the posterior parietal cortex is located before your motor area. Your motor area is around the middle size of the brain, which practically is responsible for every action that you're making. The posterior parietal cortex is an area which is responsible for planning an action. So when you want to perform an action, when you want to go to reach to this object, the posterior parietal cortex is saying to the motor area, prepare an action to reach and grasp this object. So it was interesting for what we call this higher order cognitive function, and I have studied this area of the brain, of the monkey's brain for more than 10 years. So I was wanted to go and image this area, and we have a very important sulcus in this area, which is called the intraparietal sulcus, in which on the left side we have what we call the visual area. This is responsible for your eye movements. Whenever you're moving your eyes around, that area gives command to a more forward area of your brain that generates your eye movements. And on the right side, just on the right side of the intraparietal sulcus, we have what we call the posterior reach region. This is an area that generates planning of reaching, movements. So in that case, we train monkeys to perform what we call reaching movements, memory delay instructed reaches movements, and saccade movements, both to peripheral targets. So practically we have an animal fixates on this red, dot, and then there's a green, target in the center of the screen, then a target has to do something for a period of time, then a target was presented either on the left or on the right side of space, and when the central green fixation cue disappears, that was a cue, a go cue to the animal that has to use a joystick and move the cursor to the remembering target location in order to get the reward. And we test this one with reaches and saccades. The monkey can acquire the target either using a joystick or having eye tracker that we record the location of his eyes, and we record the location he could move his eyes towards the direction of the target in order to receive the reward. So we image again, the area of the brain on the intraparietal sulcus, the area that we know that is planning reaching and eye movements, and we found, when you see here, this is actually for the eye movement task. This is the intraparietal sulcus, and this is the area that we expected to find, that this area was activated when the animal was planning to perform an eye movement. That was for us was very important, because for the first time we saw that functional ultrasound can be used to detect a functional signal in the monkey's brain. Not only that, but we found a very similar response that we know from the electrophysiology of this area. So when the animal fixates in the center of the screen, so it's not moving their eyes, the power Doppler signal, the activity we're measuring, drops down because the animals stop moving their eyes. When the target appears, we have an increase of the activity of that area, but only for the contralateral target. What I mean is that we record images from the left side of the brain. Only when the right target appears, we have an increase of the activity of the cell, because as practically the left side of your body controls the right side. The left side of the left hemisphere controls the right side of your body, and vice versa. This is how animals and humans have been built. And when we have the go signal, we have an increase of the activity both for left and right movements. This actually gave us a very nice neuron paper, and we may also the cover. Very proud of this work that we published in 2021. And now I was part of the lab that was called Chen Institute for Brain-Machine Interface. So we're interested to do brain-machine interface. So when I talk with my PI at this point, he asked me, okay, great of what you're doing, can we use to generate ultrasonic brain-machine interface? Can we use to predict what the animal will do before the animal performs the action? So we developed, this machine learning, technique, which practically we take, the data, we split them into groups. We actually split them on training and testing groups, and on the training groups, we have, vascular images of the ultrasound, when the target appears on the one side of space, and when the target appears on the other side of space. We perform class-wise principal component analysis, which practically we're looking to find features that best separate the two groups of images, and then we develop a linear discriminant analysis, an LDA, to predict the intention of the animal. And we have to do this one with a seeding trial. So we have to create a classifier that practically every image that is coming into the classifier will predict what the animal will do before the animal performs the action. And practically, we found that when the target neuron appears, it takes about 2 to 3 seconds, and this is due to the hemodynamic response delay, that the signal, the hemodynamic signal is a slower signal, but it takes about 2 to 3 seconds before we're able to predict with more than 90% accuracy the direction, of the eye, movement or the wrist, movement. We also perform, a more advanced analysis, which practically we try to predict whether the animal will engage or will not engage the task. Again, monkeys are very wild animals. Just because we have them there to work, it doesn't mean they're going to work. Okay? So what we want to predict at the seed trial level is whether the animal will engage to the next action or not. And if it engages to the next trial, whether we'll use the hand or we'll use the eye to move towards the target location. And you can see, from this confusing matrices, we did a pretty good job for predicting the task, the effector, eye versus hand, and the direction of the eye movement. So now, after that, we try to generate now a real time, because this actually set the basis. We show that there is a signal, a motor signal, on the posterior parietal cortex that we can detect with a functional ultrasound imaging to predict the intention of the animal, to predict what the animal will do. The question is, can we use this one to generate a real-time ultrasonic brain-machine interface? So we train animals to perform the same task that I described you before, but now we have 2 or 8 targets. But now, after a number of trials, we generate what actually we did, a real-time BMI. What does it mean that? It means that when we read the intention of the animal, we immediately generate the direction of the cursor without leaving the animal to perform the action. So we show to the animal what you're about to do based on your intention. Okay? And this is what we call the real-time brain-machine interface. And we show actually, based with the 2 target trials, we show that if you start training, the classifiers, you can predict the intention on real time, the direction of an eye movement with a 75% accuracy. If you train this one for a period of time, and you use the day 8 session for training the classifier, and you record the activity of the day 20, you can see that we still have a very high accuracy. This is this is actually the reason that Elon Musk started his company. Elon Musk didn't start Neuralink because he wanted to create brain-machine interface. Brain-machine interface exists from the 80s. He started his company because the main challenge that we have in brain-machine interface is that, and if you're working in machine learning, you will understand that, we need to retrain the classifier or the regression technique every time that we bring the patient into the study section. So we cannot keep the same neurons across days. Okay? And what Musk is trying to do now is trying to create a more robust, invasive electrodes for keeping the neurons without having to retrain every time the classifier. We did this one there with the ultrasonic brain-machine interface because the ultrasound can cover more areas than the single units that you put them into the brain. So we did also with 80 targets. Here we have a 50% accuracy, which is low, but way above, the significance. And even though, it shows low for the 50%, when you see the confusion matrix, the mistake that we make is on the neighboring targets. So for instance, let's say that you want to go to the 9 o'clock, the mistake that the classifier will do is that to go either to 7 or 11, not to more, to the other side of the space. So based on that, we're proud that we published a Nature Neuroscience paper about a few weeks ago, and now there's a big things in the media that our group, with collaboration with the group that we're working with Caltech, USC, and UC Riverside, developed the very first ever ultrasonic brain-machine interface. Okay, now why this is important? Okay, why this is important? Why we want to create ultrasonic brain-machine interfaces? What is the advantage? Okay, so what we have so far, it's only invasive technologies. So invasive technologies, it requires to have a major surgery. Okay, by the way, on my slides, I have some graphic figures. I try to minimize them and use them only if it's necessary to explain, like things. So excuse if somebody don't feel a bit like distracted with these images. But here, so what you're doing, you're removing half of the scalp and you place electrodes into the brain. Okay? Now, this is actually one of our patients that I was working with when I was at Caltech, a 60-year-old female tetraplegic with a complete spinal cord injury at the cervical level of C3, C4, so she cannot move anything from the neck and down. And what actually we train her here is to perform center-out reaching movements by just imagine that she's moving here, like playing a video game and it has a fake joystick. This is just a wrap, there is nothing, like here. And imagine that it's moving, like her thumb as she was controlling a joystick. We take the signal, we decode it, and as you can see here, it has to move. Can you see the green cursor here on the screen? Is it visible? Because I cannot see here. Like the green cursor into the Q target location. And as you can see, she's doing very nice to reach into the direction, of the target. It's very nicely, controlling with her mind the direction, of the target. So based on that, we published another nice paper in Neuron. The first author, it's very interesting, is my wife. That we're working together for more than now 10 years, and we have done, very amazing things together. So the problem now with that is, as I said, it requires to do surgery. Not only that, there's something worse than this. You have to replace the electrodes every 3 to 4 years. As soon as you put something invasively in the brain, you traumatize the brain. You are killing the neurons. The neurons, sooner or later, will die. And these patients, they have to go into surgery to replace this electrode. So if you want to create brain, this cannot be commercialized. Regardless of what people are saying, I don't think that someone wants to have brain surgeries every 3 years to replace the electrode. So we're looking for something new, okay? And we think that the ultrasound can solve this limitation. Okay, what did I say before? The skull is the biggest problem with us. We have to remove the skull, okay? So here we have patients that we have what we call decompressive hemocraniectomy. A very complicated term, but a very common surgery. So patients with stroke, patients with traumatic brain injury because of a car accident, if there is a bleeding hemorrhage in the brain, the very first surgery, the very first treatment that they will receive in a hospital is to remove the scalp so that they release the pressure, they reduce the pressure on the brain. Okay? Now, if they remove the scalp cannot go back because this has to stay out for months, and then you cannot replace them back into the brain. So what actually they have to do, they have to be reconstructed. And usually, they were reconstructed with titanium mesh. This is actually what the neurosurgeon is using. Really bad for ultrasound. So for years now, we're working, with our colleagues from USC to develop, a window into the brain. And we came up, with some companies that are working with this cranial, window. That's a glass that looks like that, goes and restore, reconstruct the scalp of the head, but also, because it's glass, we can record from the brain using functional ultrasound, imaging. So this work here is, we have it under review, which actually, with very positive comments with science, translational medicine. So we have, our first, patient that he got, he has a decompressive hemocraniectomy, and here, he's playing a video game. He's connecting, the dots, using, a joystick, starting, with 1 minute of resting state, then 30 seconds drawing, 1 minute of resting state, and so on. And this is actually what he has to do here, connecting, the dots. And this is the area that we're recording. It is around the sensory and the motor area of the brain. And as you can see, we identified areas in the brain. This is the ROI2, the region of interest 2, in which you can see there's a very nice increase of the hemodynamic signal when the patient is performing an action. So this is the very first proof of concept that we can also translate this technology into humans, and we can detect a very basic motor signal that has to do with performing an action. The same patient action we have used it to play the guitar, we have other tasks, very consistent results. So we're closer now to develop the very first ultrasonic brain-machine interface for human patients with decompressive hemocraniectomy. Okay, now, one thing that always bothers me when I start, I switch, to neuroscience, is that somehow, we completely ignore the spinal cord. We have all of these patients that have injured the spinal cord, but every single neuroscience that I know, they focus in the brain, and myself, including myself. And I was always wondering why we're doing that. And probably I thought because spinal cord is not very important. Although, evolutionary is the very first step in the development of the central nervous system, and is the host, actually, of very important, like functions, like breathing, chewing, swelling, bladder control, sexual function, all of them located, into the spinal cord. But we completely ignore. We make like that we don't have a spinal cord. That's just a cable that is transferring information from the brain to the peripheral nervous system. So if you look, and I stop here, additionally to 2012, you see how many publications we have every year in PubMed related to fMRI in the brain. You see, about the same time, how many publications we have, like on the fMRI or the functional imaging overall in spinal cord. Look at the scale. Like, for instance, 2012, that we published about 20,000 journals related to fMRI in the brain. We have about 8 to 9 journals on the fMRI for the spinal cord. Crazy. Completely ignoring, that area, of the central nervous system. And we know that this is such a very important area. We have cases, we have animals that they survive for a few minutes, either, to a few months, like Mike, the headless chicken, who survived 8 months after the animal lost, his head. So we say that this cannot be true. I mean, the spinal cord can do something more than to be a single ape, since, we have evidence that we have a lot of functions there, and also have cases that animals survive without, the head. So why we don't do that? And usually, this is one of the things that I learned with a lot of pain. If people that are not interesting for in areas that you're studying, it's not because they're not interesting, it's because practically they cannot do it. This is very important to keep, for your whole, this is regardless of the research that you're doing. So the problem now is that spinal cord is a very unfriendly environment for most of the imaging technology we have. Because number one, spinal cord is very small. The diameter is a few centimeters. Number two, is surrounded, by all of the different organs, like lungs, thorax, like the neck muscles. All of them, they generate tremendous amount of noise to the signal that you try, to record with fMRI. Besides that, we almost have no coils that can be used for functional MRI in the spinal cord. So when I went to UCR, I thought that now, as an independent PI, I don't have anyone to persuade that I want to do research on the spinal cord. The only one that I have to persuade is the neurosurgeon. And I'm very lucky that I'm collaborating with the head of the Neurorestoration Center at USC, who is, interestingly, has a PhD first in chemical engineering before he became a neurosurgeon. So he's an engineer. He can understand, what we want actually to do. And he actually the one that he initiates, found the patients that we have to go to the spinal cord. But the most important thing is that always in clinical trials, you need to identify the appropriate patients. And one of the major issues that we have, one of the very serious problems, like disease that we have, disorder that we have, is the chronic pain. Especially, in academia, chronic pain actually runs, I would say, almost all, researchers, because of the way of our life, or the way, that we're sitting, on a chair, for hours, like 24 hours. So chronic pain, is the first leading cause of disability worldwide. It affects, millions of people, and practically there is almost no treatment. Okay, like people, they try, to do, with painkillers, with opioids, physical therapy, like surgeries, and then at the end, we have what we call the failed back syndrome, surgery, which the patients that they did everything and they have a very miserable life. So the only treatment that exists after that is what we call the spinal cord stimulation. So the patients, they come into the OR and they do, the surgeon is going and place a stimulator into the spinal cord, like a pacemaker. And this pacemaker generates, electrical activity into the spinal cord. So with that, what we believe, because we don't know the mechanism, very common to have treatments without knowing the mechanism. What we believe that happens is that this stimulation reaches to your brain faster than the pain. And somehow it masks the pain and creates a paresthesia. Patients, they claim of what actually we're feeling like a tickling Now, the pain goes away, but now we're feeling like a tickling into our spinal cord. Now, unfortunately, you have a 45% failure rate. This is huge. Because these patients, if they fail, there is nothing else that we can do. They're going to live in their whole life with chronic back pain. I met with some of these patients. I can tell you, it's horrible. I know cases that people even committed suicide because they couldn't afford the pain that they had, like on their back. The reason actually that we have this kind of low performance is because we don't know the mechanism of function. We have no idea what we cause to the spinal cord when we stimulate it. Why? Because we never image the spinal cord when we stimulate it with the epidural spinal cord stimulation. So what actually we did here, we identified like patients that they go into surgery to implant with epidural spinal cord stimulation. Here you can see, this is my cursor. Oh, it's easy, right? So I can use my cursor. So here, you see, what we call a laminectomy. So practically, the surgeon is creating an incision, opening at the area of the T10, and remove the bone from the spinal cord. And we have here, and we go and we place this is how it looks like. This is actually the ultrasound, probe that we place it inside, the spinal cord, and having also the electrodes that they go into the spinal cord to stimulate and image, the spinal cord. So this is actually a cross-section of the human spinal cord with the white and the gray matter, and the green is the field of view. This is around of where we image the spinal cord. And this is a beautiful image. For the first time, we have the vascular map of the human spinal cord. And as you can see with this discontinuous line is the dorsal surface. The dorsal surface is very important. The dorsal part is responsible for the sensory information. The ventral part is responsible for the motor information. So, what actually we did now, we started with a baseline of 5 minutes, and then we stimulate on and off, we turn on and turn off the stimulation with, for 10 times, with 30 seconds off and 30 seconds on. And this I'm going to show you here is a scene trial of the functional ultrasound that images power Doppler signal changes with the stimulation starting with 5 seconds before we turn on the stimulation. As we go now, when we turn on the stimulation, you see a very strong hemodynamic signal changes that happen into the dorsal part of the spinal cord, in which when we turn it off, it's going to go back into the baseline. So we saw that we have a technology now that we can image the hemodynamic change that happen into the spinal cord, which is generated by the epidural spinal cord stimulator. Okay, these are 4 patients that we have different, as you can see, different, planes, all of them very similar results. And the nice thing is that we identify, areas in which the activity increases of these areas when we turn on the stimulation, or the activity is suppressed when we turn on the stimulation. Surprisingly, we found individual differences. You see that not all of them, they saw the same response. Some of them, they have strongest, the protocol is exactly the same. Amplitude, intensity, voltage, everything is the same. People that have different responses. This is the problem in medicine, okay? We know, we try, the main trend these days is to do the personalized medicine, to make medicine to be specific for every patient. Otherwise, you're going to have 45% failure if you give the same protocol to all, patients. So here you can see some of them, elevates faster than others. Some of them didn't return back to the equilibrium, to the baseline when you turn off the stimulation. So it showed complete different, responses. So what actually we try now to do now, we try to create a machine learning technique that can predict the effectiveness of a stimulator, of the stimulation protocol, with just a scene trial. So what we want to do is we want to give eyes into the neurosurgeon. When the neurosurgeon has the patient anesthetized and place the probe, to be able to go and record from the area of the spinal cord to tell them whether the protocol that we are using is effective for changing the hemodynamic signal, or you need to modify the protocol. So we record from that area of the spinal cord, and then we split the area, the images in stimulation off and stimulation on trials. We flatter them into big vectors, and then we randomize them in 75% training and 25% testing data. We perform classic Y-specified component analysis with linear discriminant analysis, and we generate we make predictions in terms of the effectiveness of that protocol. And what also we found is that on average, we're using like different size of the training window. So practically we didn't take all the 30 seconds, but we started from 5 seconds and we start increment by 1 second to see if the training size of how many data we're using for the training size affects the performance. And what as you can see, we have a very nice prediction up to 90% for a training window of 10 to 15 seconds. But if you start putting more into the classifier, the performance starts going down. So it's very important when you create like a statistical, a machine learning technique for predicting the effectiveness of a protocol to make sure that the data that we're going to use for training the classifier can be optimized to the point that can give the maximum information into the surgeon. And practically we found that a decoding accuracy, a training window for about 25% of 25 seconds of training window and 17 seconds of testing. So I train my classifier for 25 seconds and I'm looking the data of the 17 seconds that I record will give me about 100% accuracy to predict the effectiveness of a protocol with a single trial. So based on that, we create of what we call, we want actually to create, and this actually it's a proof of concept, what we call the closed loop clinical neuromodulation. So practically we have a neuromodulation system, a clinical system that can image the effect of the neuromodulation, something that doesn't exist, like in surgery. So the other thing now is that we also use what we call the transcutaneous neural stimulation. Okay, so here we have cases in which we don't go invasively, but we have signal, we have stimulators that we place them outside, non-invasively into the back of the patient, and we start stimulating the spinal cord to signal the effects. And actually, this is here. We have two cases with low and high amplitude of the transcutaneous stimulation. And very nicely, we found that we can predict the differences between a low and a high frequency. You can see when you have a low frequency, there is no any hemodynamic changes. When we increase the frequency, we have an increase, we increase the amplitude, we have an increase of the hemodynamic changes. This was important and was asked actually by one of the reviewers on the neuro paper that we just published, which says that we want to see the specificity of your technique. Whether your technique can also predict changes of the protocol, since we want to sell this technology as a closed-loop neuromodulatory systems. Okay, take-home message. We demonstrate the first in-human functional ultrasound image of the spinal cord. The functional ultrasound image can capture and characterize spinal cord hemodynamic changes induced by electrical stimulation. The electrical stimulation causes regional change in the spinal cord hemodynamics. fUSI can predict the state of the spinal cord with a single trial, and this is a new avenue for developing a real-time closed-loop neuromodulation treatment and technology that currently doesn't exist. Okay, for the next few minutes that I have in order to finish my talk, spinal cord injury, very important. Okay, I'm working with these patients for many years. I mean, it's a situation that nobody wants actually to be. Okay, they suffer. Interestingly, if you haven't worked with these patients and they ask you, what functions do you think that they want to restore? If they can do immediately now. I guess that 99%, almost all of you will be that they want to walk again. This is very low. This is not the major problem with these patients. You'll be very surprised. The major problem with these, and actually let's go back here, sorry. All these companies that you can see here, like Kernel, Neuralink, all of these companies, BlackRock, they're working on developing brain-machine interface systems for restoring a function that was not the top one function for these patients. There is something which is more important than that. If you see the literature based on, talking with these, patients, you will see that the two functions we want to restore, number one, sexual function. Number two, bladder control. They will die because they cannot control the bladder. Because what happens to these patients when they cannot control the bladder, they use catheters in order to remove the urine from the bladder. Don't forget that somebody has spinal cord injury doesn't have also sensory information. So what happened? When they get UTI, and they get UTI very often, they don't feel it, but they got sick. The virus has to go all the way back to the kidneys to get very sick and to hospitalize. Like the patient that I saw you, Nancy, the woman patient that I saw you, Within a year, she has to go 3 to 4 times to the hospital because of UTIs. At the end, they were going to lose the kidneys. So we want actually to create what we name, and we name that as a spinal cord machine interface for restoring bladder control. But to do that, the very first question that I have to ask, is there a signal in the spinal cord that controls the state of the bladder? So what happened now? Number one, we have no idea where in the spinal cord there is the bladder network. No idea. Nobody has ever imagined how the spinal cord signal changes based on the state of your bladder, whether it's full or whether it's empty. So we take, the same patients that we have, for chronic pain, and they participate in this experiment that we use a urodynamic way to fill and empty the bladder with saline. So we start, filling the bladder for about 6 to 7, minutes. We start another, filling, and then after, about 10 minutes, we start, reverse the pump and start, empty the bladder. Within the bladder, we insert also catheters that can measure the pressure, of the bladder. And what actually this actually can see here, this is pressure curves. This is actually what happened when you start increasing, when you fill and empty, the bladder. This is measured the pressure, of the bladder. So we perform again a machine technique. We take the data, we split it into 2 categories, emptying, versus filling. We did a statistical, we did class-wise spatial analysis with support vector, machines. And practically, we try to find of how many data we need to use to get the best prediction between the hemodynamic signal and the bladder control. And this is the beauty, that we get. What actually you can see here, there is different areas of the spinal cord that controls, the bladder. And what you can see here with red, actually with the gray, is the bladder pressure, and with red is areas, the average activity of the hemodynamic signal of that, areas that are, as you can see, strongly correlated, with the bladder pressure. So practically we found areas into the spinal cord in which the signal of that areas is correlated strongly with the bladder of the patient. We want actually to see now whether we can predict an incoming voiding, whether we can predict that the patient is about to pee. Problem here is that you cannot have patients to pee in the OR. It's not allowed. And this is the time that we have to go to animals. So we get, animals, and we perform a laminectomy on the T12L2, and we fill, the bladder, but now we let the animals to spontaneously pee. So this is actually a vascular map, of the spinal cord. I'm gonna, pass this. So we start, with baseline. We fill the bladder, with a 0.1 microliters per minute, and we hold the pressure, we hold, the pump for filling the bladder. We do this one twice, and practically, what actually we developed another statistical, another machine technique, and we found that we can predict an incoming, an upcoming, voiding 5 seconds before that happened. This was very important finding because we found that there is a signal of the spinal cord. We can take it, we can decode it, and we can tell you whether the animal is about to pee 5 seconds before the animal pees. Okay, do I have 3 or 4 minutes to finish? How am I doing about time? Am I...
A few more minutes.
A few more minutes, okay. Now, last thing, but not least, epilepsy. I mean, at least I have many people that I know, before even going to the States, that they have epileptic seizures. Epilepsy is it's a very common chronic disease that affects many people worldwide, more than 80 million people, 70 to 80 million people worldwide suffering from epilepsy, in which we have a group of neurons that they send a raw signal that cause recurring and unprovoked seizures. So the seizure is a burst of electrical activity. This is what you can see here as a normal brain. This is a brain with a focal seizure that you can see a very strong burst of activity, or more generalized seizure, 30%, more generalized seizure, very difficult to treat, that is everywhere in the brain. People with epilepsy will die. If you don't treat them, they will die. The very first course of treatment is to put them into drugs. Unfortunately, this thing doesn't work for everyone. 30% of people, they do not respond to drugs. So they have to do something which I found very brutal. So they take them out of medication 2 weeks before the surgery. They remove half of the scalp, and they place electrodes in the potential areas of the brain in order to find the seizures, which area they have to remove. And they do this one, this is actually an X-ray, a real X-ray for one patient that has all these electrodes deep into the brain, or we have these echoes, the grid that we do in the brain. Now, this is not a problem, believe me or not. This is not the major issue that they have. The major issue they have is that they have to take them out of medication because they want to have seizures, to find out what are the seizures. I found, as an engineer, that this is very cruel. It's like for me to go in a mine to find the bombs and to have felt an explosion, and then you say, here's the bomb, oh, thank you. But we want to find the areas without having to take these people out of medication because it takes 6 months to 1 year to put them back to medication and to stabilize the condition. So somebody asked me, so why they don't go to surgery, open the brain, and image the brain with these techniques to find the seizures? Anyone wants to guess? I mean, it will be a straightforward question, right? Why do you have to put them into the clinic for 2 weeks waiting for the seizures? Just put them, like in the OR. Open the brain, please.
Because the seizures don't happen that often.
This is one good point, but it's another one also. When the brain is anesthetized, it's not seizuring. As soon as you anesthetize the patient, the brain stops giving you seizures. So it's a chicken egg problem. Okay? So, the big question in neurosurgery, can we detect what we call seizures during the interictal state, when the brain is not, seizuring? So we have, like these patients that they go into, surgery. We put, like the ultrasound. This is the only graphic picture that I have to show you. So here, it's one of our patients. Here, is the echoes that we put them, into the surgical room, and this is the ultrasound system that goes into the areas that have been identified from the neurosurgeons before we went into the surgery. And we record functional ultrasound imaging for about 60 to 180 seconds. So this is actually the vascular map of areas that they give seizures, healthy areas that was before surgery, and healthy areas that stay back. Now, there is another major problem here, guys. When you have an area that is seizuring, and you have another area which is seizuring, another area that is seizuring, it doesn't mean that these areas are bad areas. The brain is a network, right? So a seizure in that area can induce seizures to healthy areas. So it doesn't mean that you have to remove the healthy areas, because you can remove the bad areas, and the healthy areas can stay behind, right? The problem is that you don't know which one to remove, because there is no signal. The only thing you have is spikes, seizures or no seizures. I have no other information. So what actually we did, we tried to come up, and that actually for me was the most challenging problem. I tried to come up with an idea. I tried to come up with a biomarker that can tell me that if I place the ultrasound probe in an interictal state with no seizuring, it can tell me that this is a bad area that has to be removed. Okay? So what actually we did, reading the literature, you know that areas that they have seizures, they have high synchronization. They seizure together. So what else we did, we get, like these images, we discretize them, and we perform a pairwise patient correlation analysis to create a functional connectivity matrices as a measure of local synchronization. And this is actually what you can see here for our first patient. Like, this is areas, the local synchronization of areas that has to go away. These are healthy areas before surgery, and this is healthy areas after the surgery. And with that, we have one of the best results I ever saw in my 4 years now as a PI, in which the local synchronization is very strong for the seizure areas, is strong also for the healthy areas, but after you remove the bad regions, the activity of the healthy areas is going down. So this is a very good indication that the neurosurgeon can start removing areas, whether areas that we have some question marks whether we should be removed or not, we should wait and using this interoperatively, this technology, to evaluate whether we should remove or not, like these regions. Last, and I probably this is my last, is whether we can use like neuromodulation treatments. before removing the areas of the brain, let's use something to modulate the brain without using, like drugs. Again, these patients are drug resistant. They don't respond to drugs. Let's try to see if we can, modulate the system. So here we use, what we call a gecko. Is a technique, that goes. It's a neuromodulatory system that goes and stimulates the perineal, nerve of the human, patient. If I play that, you can see this is during surgery. Look at here or the toe of the patient. How it reflexes. And what actually we did now here, we want to see if this somehow reduces that measurement that we found. Because if I tell you that the local synchronization is low for areas that they don't give seizures, I will try not to push my technology to the point to see if I place that technique, if I can evaluate the effectiveness of treatment like the PNS stimulation into the areas that they give seizures. So we did again the same idea. We performed functional activity analysis, and we have now a sliding window. As you can see here, we start with the patient 1. This is when we start imaging the brain, and then at this point here we're going to turn on the stimulator, okay, and see the changes on the functional activity. We start, we go very high, right, because we have these areas give seizures. As soon as we turn it on, boom. Patient number 2, we start it's a seizuring area. It gives seizures this area, okay. We turn on the stimulator, boom. Third patient, the same thing. We start in very high synchronization. We go, we turn on the stimulation, down. So we prove here something crazy, something we couldn't believe, is that we may come up with a new technique, completely non-invasive, just stimulating, the peripheral, nerve to suppress epileptic seizures in these, patients. Now, imagine this technology versus opening the scalp and brace electrodes to scoop out areas, of the brain. Of course, everything is very preliminary, you see. We haven't even touched in terms of applications. We don't know how to handle this data because we believe that we are in front of something really, really big. But as I say to my students, you don't need to be first, but you have also to be the best when you publish something. Okay, take home message. The functional ultrasound imaging is capable of identifying epileptic areas during intellectual period. Local synchronization seems to be a robust biomarker for epilepsy. The peripheral nerve stimulation reduces local synchronization in epileptic zones, and we also test other neuromodulatory treatments like the RNS, the restorative, responsive neurostimulation, and the vagus nerve stimulation. With that, of course, none of this could ever be done without having a huge team of excellent, scientists. Starting, with Charles Yu, the head of the Neuro-Restoration Center at USC, that provides all of this, clinical work. Different, students, postdocs, undergrads, urologists, pediatric neurologists, and you name it. And of course, if you want to join us, we're very happy to get talented, students who are interested to do a PhD, on the area of biomedical, engineering. You're gonna have fun. You're gonna be in Los Angeles. Of course, again. This is an advertisement picture. Believe me, on my PhD, I think I never visited, this, place. But again, it's a very fun, area, and this is, the campus at UCR. Thank you.
Να ευχαριστήσουμε τον κύριο Χριστόπουλο για την εξαιρετική και πολύ ενδιαφέρουσα ομιλία. Ίσως μια-δυο ερωτήσεις. Και μετά, ίσως, κατηδίαν με τον κύριο Χριστόπουλο, αν κάποιος έχει κάτι παραπάνω. Ο κύριος Βάρας,
Συγχαρητήρια για την αγαπητική.
Ευχαριστώ πολύ.
Θέλω να δω στα αγγλικά, στα ελληνικά.
Αλλά πούμε στα ελληνικά, Στα ελληνικά, εγώ θα λέγα. Όπως θέλετε εσείς, όπως νιώθετε καλύτερα. Δεν ξέρω, πώς θέλετε εσείς.
Όπως θέλετε.
Εγώ είμαι από την περιοχή του Microvascularization. Ξέρω αρκετά πράγματα για περίπτωση, αλλά όπως θα ξέρω εσύ. Ήθελα να ρωτήσω το εξής. Εσείς ουσιαστικά κοιτάτε blood perfusion, έτσι δεν είναι?
Ακριβώς, CPVs.
Ναι. Και το οποίο το blood perfusion σε τι βάθος, δηλαδή αυτό που κοιτάτε, το χρώμα αυτό, είναι επιφανειακό.
Εξαρτάται το frequency. Το 15
το ξέρω αυτό, αλλά Πού κοιτάτε, εμφανιακά ή.
Και στα δύο. Δηλαδή σε κάποια studies κοιτάμε high frequency, οπότε κοιτάμε 1 με 2 εκατοστά από το brain surface. Σε κάποια που θέλουμε για deep structures έχουμε low frequency probes, 2 MHz που πας μέχρι 8 με 9 εκατοστά.
Τώρα αυτή είναι η ερώτηση που έχω. Το πρόβλημα που εγώ βλέπω ότι μας παρουσιάστηκε βεβαίως σε μια τέτοια παρουσίαση ξενάγησης, προφανώς πρέπει να μας κάνετε stimulate στις ιδέες σας, ας πούμε, και να μοιραστείτε τον ενθουσιασμό σας. Αυτό το οποίο θέλω να ρωτήσω είναι το εξής. Εντάξει, ακούγονται τώρα.
Να γραφτείς την κάμερα.
Λοιπόν,
Το κλείσες τώρα. Λίγο πιο κοντά.
Λοιπόν, έλεγα λοιπόν το εξής, ότι αυτό το οποίο εγώ πιστεύω ότι υπάρχει πρόβλημα και πρέπει να μας πείτε δύο λόγια γι' αυτό, είναι το ζήτημα ότι υπάρχει contribution από πάρα πολλά. Το vasculature του εγκεφαλού είναι πολύ μεγάλο. Σίγουρα έχετε contribution από πάνω, από κάτω, από δίπλα, από όλα αυτά τα μέρη. Δεν μπορεί να. Δηλαδή, πιστεύω το specificity αυτή τη υπόθεση θα είναι ένα πρόβλημα που πρέπει να αντιμετωπίσετε. Δηλαδή, δεν υπάρχει μεγάλη σιγουριά από πού παίρνει κανείς το σήμα. Και επίσης δεν υπάρχει καθόλου σιγουριά όταν λέτε σε κάποιο subject να κάνει κάτι, ότι αυτό ταυτόχρονα υποσυνείδητα και μη δεν κάνει και κάτι άλλο.
Αλλά τώρα μιλάμε, ανοίγεται μια κουβέντα τη στιγμή που είναι το βασικό πρόβλημα στο neuroscience. Δηλαδή τώρα πρέπει να αρχίσουμε να λέμε για παράδειγμα ότι resting state που λένε δεν υπάρχει.
Ναι, δεν υπάρχει.
Γιατί κανείς δεν κάνει resting state.
Εγώ θα περίμενα δηλαδή τα σήματά σας με βάση αυτή την ποικιλία των πραγμάτων που υπάρχει να είναι γεμάτο θόρυβο. Και να έχετε τεχνικές να δείτε. Αντίθετα τα σήματα τα είδα πάρα πολύ.
Λοιπόν, θα σας πω για ποιο λόγο γίνεται αυτό. Επειδή έχω δουλέψει με όλες αυτές τις τεχνικές που λέτε. Έτσι, δηλαδή, έχω βάλει τα χέρια μου από το EEG, MEG, fMRI, you name it, όλες αυτές. Η δυνατότητα που έχει το functional ultrasound imaging είναι ότι μπορεί να κάνει detect slow blood flow. Γιατί αυτό είναι σημαντικό. Αυτό έγινε λίγο mask στην ομιλία μου. Αυτό γιατί είναι πολύ σημαντικό σε σχέση με το fMRI που είναι noise signal. Γιατί η περιοχή η οποία σε μας ενδιαφέρει να κοιτάξεις, να βρεις, είναι οι περιοχές που έχεις πολύ slow blood flow. Ποιες είναι οι περιοχές? Τα καπίλαρες. Όπως έχουμε τις αρτηρίες που έχουν τα μεγάλα vasculature και φτάνεις μέχρι την πηγή, η οποία έχουμε τις πολύ μικρές vessels, τα οποία μπαίνουν μέσα στο κόρτεξ. Αυτό λοιπόν το πράγμα είναι το οποίο εσένα σε ενδιαφέρει να δεις. Τώρα, εάν πιάσουμε, αυτό δεν είναι μόνο θέμα του φους, είναι θέμα όλης της επιστήμης του neuroscience. Ότι για παράδειγμα, όταν εγώ σου λέω να κάνεις μια κίνηση, πού ξέρω εγώ ότι κάνεις την κίνηση αυτή και θα σκέφτεσαι κάτι άλλο. Αυτό όμως είναι το θέμα, είναι κάποια assumptions τα οποία πρέπει να κάνεις στην επιστήμη. Διαφορετικά.
Υπάρχει όμως και το άλλο ζήτημα και άλλη μια ερώτηση θα κάνω και αυτή που κάνω τώρα και δεν θα απασχολήσω.
Πείτε μου, είναι πολύ διαφορετικό.
Θα μιλήσουμε και μετά ενδεχομένως. Αυτό το οποίο θέλω να ρωτήσω είναι το εξής. Ότι παλιότερα βάζανε micro bubbles για να βρίσκουν.
Υπάρχει αυτό, το έχουμε.
Στα καπίλαρες, πού θα πάει το micro bubble?
Κι όμως, υπάρχει τα gas vessels τα οποία χρησιμοποιούν τα microbubbles, όλα τα gas vessels τα οποία τα κάνουν. Υπάρχει paper από το Einstein Institute, αυτή τη στιγμή στο Nature Methods, στο οποίο δείχνει ότι μπορεί να πας 5 micros με τα microbubbles, με το λεγόμενο ULM.
Δεν μας δείξατε κάτι με microbubbles.
Γιατί δεν χρησιμοποιώ. Το βασικό πρόβλημα το οποίο υπάρχει είναι ότι δεν μπορεί να κάνεις clinical trials με microbubbles. Δεν μπορείς να βάλεις σε ασθενείς microbubbles.
Υπάρχουν. Το contrast είναι πολύ μικρό. Θα ακούσετε και η impedance σε slow motion, σε μικρό αγκαίο, υποθέτω ότι θα είναι μικρό.
Βέβαια, ξανά.
Για να δεις perfusion, όχι για να δεις.
Η ερώτηση είναι τι θες να κάνεις. Γιατί μπορεί να είναι μικρό, αλλά όταν δείχνεις ότι έχεις ένα prediction value of more than 90% to predict movements, or to predict an income and upcoming like voiding of the rat, that for me is enough. Because always depends on what the question you have to ask, right? Now, if you ask me now, where is exactly in the brain is that area? I might not have a good answer for that, okay? Because I may need to have, like microbubbles. The problem with microbubbles, again, there are FDA-approved microbubbles. The problem is that some of the neurosurgeons, they don't want to use it because they can create stroke and create, like other participations, and nobody wants to put their hands in this, like difficult situation, okay? But I agree that if we start discussing about specificity, about give a very quick, like thing of the experiment so with the training, with a brain-mass interface that we control with the invasive electrodes, and we learn how to perform reaching movements. We have done the same experiment with monkeys. The same problem with monkeys there is that you don't know if you ask the monkey to perform an action, if the monkey is using a hand or is using other parts of the body because the monkey cannot talk. So the advantage with humans is that they tell us what to do. Okay? So always we have this problem in neuroscience that, and I give you an example, the very common example, the resting state. Do we have a resting state? Because my resting state can be, I'm sitting on the magnet, and I'm imagining my talk. You can imagine about your drug, your gland. Somebody can imagine about like an upcoming, meter. So practically the resting state is different. Okay, but again, there are some assumptions, as always do in science, but we have to start from there.
Okay, so the last comment, and I give up. Okay, is that
The previous one was the last one.
Okay, θα την κάνω όμως, γιατί λέω Απόστολος. Λοιπόν, εγώ αυτό που θέλω να ρωτήσω είναι το εξής, ότι το τελευταίο ζήτημα. Εφόσον είστε invasive, δηλαδή ουσιαστικά πρέπει να ανοίξει ένα παράθυρο, όπως λέτε, okay, τότε γιατί δεν χρησιμοποιείτε κάποιο module με multimodal imaging και λέτε μόνο τους υπέρηχους, ας πούμε. Στον υπέρηχο δεν μπορεί να δεις optical imaging, hyperspectral imaging. Επίσης μπορείς με τα optical που δουλεύω εγώ να μπεις με μια πολύ μικρό hall από ένα δεδοσκοπείο και να κάνεις laser spectral interferometry και να βρεις perfusion με τρομερή ακρίβεια. Αλλά μπορεί σίγουρα το ultrasound να δεις βαθύτερα που δεν βλέπουν οι οπτικές τεχνολογίες. Επίσης, οι οπτικές τεχνολογίες μπορεί να δεις επίσης και το blood oxygenation, oxy, πράγματα, τέτοια πράγματα. Το σκέφτεστε να κάνετε multimodal...
Το να κάνεις multimodal imaging είναι κάτι που φανταστικό. Το μόνο θέμα που μπορώ να πω είναι ότι πρέπει να το εγκρίνει και το FDA. Δεν μπορείς να πας εσύ και να πεις ότι εγώ θα βάλω αυτό στο χήμα, γιατί εκεί πέρα είναι κάτι που πραγματικά όμως είναι μέσα στα επόμενα βήματα. Έτσι, είναι πολύ νέα τεχνική. Πρέπει πρώτα να αποδείξουμε ότι δουλεύει σε κάποιο βαθμό και να την ενώσουμε μετά με το φωτομικρόσκοπι, με όλες αυτές τις τεχνικές οι οποίες μπορεί να κάνει, optical imaging και so on.
Ωραία, μπράβο, συγχαρητήρια.
Ευχαριστώ πολύ.
Αν υπάρχει καμία ερώτηση ακόμα από το κοινό, όχι. Ο κύριος Μπάλας μας κάλυψε πλήρως. Ευχαριστούμε πάρα πολύ.
Και εγώ ευχαριστώ πάρα πολύ.
Ευχαριστούμε πάρα πολύ τον κύριο Χριστόπουλο. Είναι πραγματικά χαρά μας να τον έχουμε. Εξαιρετικά ενδιαφέροντα πράγματα και τα οποία, όπως γενικότερα το biomedical, έχουν επιπτώσεις στη ζωή πολλών ανθρώπων. Γιατί είδαμε ανθρώπους που το αποτέλεσμα της έρευνας σε 5 χρόνια μπορεί να τους κάνει τεράστια διαφορά στην ποιότητα της ζωής τους. Ευχαριστούμε πάρα πολύ.
Ευχαριστώ πολύ.